Great. So welcome to everyone. Good morning, good afternoon, and good evening to YPOers and friends around the world. I'm Dick Simon, the co-founder and learning officer for the YPO Precedence Action Now chapter and founder and chair of this psychedelic medicine for mental health group within YPO. I spent all of my time working to help advance this work, both because of the incredible data and evidence for its efficacy, addressing otherwise intractable mental health issues, and on a very personal note, having experienced and dealt with mental health issues within our family. So today's call will be an hour with question and answer session following a presentation. If you have questions, you can submit them via the chat feature on the Zoom screen, and we'll try to get to them during the Q&A session. Please note that the call is being recorded and a recording link will be sent out approximately 24 hours or so after this live call. So the work that our speaker today is involved with is looking at psychedelic medicines for mental health, shifting consciousness, and breaking down psychological barriers. We're really privileged to be joined today by Dr. Matthew Johnson, professor of psychiatry and behavioral sciences at Johns Hopkins University School of Medicine. Working with psychedelics since 2004, he's one of the world's most widely published experts on this area, on human psychedelic research. He published safety guidelines in 2008, which helped to resurrect human work with psychedelics. He published the first research on psychedelic treatment of tobacco addiction in 2014, and the largest study of psilocybin in cancer distress in 2016. Matt also conducts behavioral economic research on the psychology of addiction and sexual risk. He's been widely interviewed about drugs and addiction, including by the New York Times, the Washington Post, the Wall Street Journal, BBC, CNN, Fox, NPR, and Michael Pollan, who I'll mention at the end, is an upcoming speaker in our series. And very cool, Matt's Twitter handle is drug_researcher, so very good. So it's now my pleasure to turn over this call to Matt, who'll speak for about 25 minutes or so, and then we'll go to Q&A. Matt, thank you so much for being here.
Thank you, Dick. Let me know if you hear me okay or not. But want to thank you, Dick, and Alex for roping me into doing this. So it's a pleasure to present for you all, and I'm really, I'll show you some stuff, but I'm really looking forward to that discussion component we have later on. Let me see if I can go ahead and get my slides shared. Let's see. Okay. Let's see. I'm not seeing anything. I think I didn't do that right.
No, Matt, it was being shared.
It was? Okay. I just undid myself then. I'll do the same thing again. Okay, very cool. All right, wonderful. So hopefully you're seeing that. So thanks for bearing with the inevitable Zoom, at least a few seconds of technical glitchery. I'm going to show you what I think are some serious data that are very supportive of a very promising future for psychedelics and the practice of medicine and perhaps even beyond. One of the bigger trends, though, I think in psychedelic science is that, we're understandably very, very concerned about people taking our research seriously. And I think the data speak for themselves, but I also think there can be a risk of going too far and taking yourself too seriously. So sometimes I like to throw in a little psychedelic joke, and I've come up with a new one just for you folks. Okay, so here it goes. I only break out a new one every 10 talks or so, so it's not every time. All right, so why did the psychedelic therapist, why did she switch to a larger session room when moving from conducting psilocybin sessions to conducting LSD sessions? Why did she need a larger session room when moving from psilocybin to LSD sessions? Because there wasn't enough shroom.
Ah,
The beauty of Zoom is I can only hear one, the groans from Dick rather than probably, a couple of hundred, and no tomatoes will reach me. So I'll move on to the serious stuff. Let's see here. Okay, do you want to just disclose some advisory relationships with some companies that are developing psychedelics and related compounds as medicines? What I'm going to be telling you about is largely relates to psilocybin, and so that's the active agent in over 200 species of mushrooms. It's a classic psychedelic that puts it in the same specific pharmacological class as LSD and mescaline and dimethyltryptamine, which is an ayahuasca. It hits a very particular brain receptor, the serotonin 2A receptor. So some other drugs that have some overlap, like MDMA and ketamine, they're sometimes called psychedelics, but they're not classic psychedelics. They're different enough to be in their own.
Matt, I don't mean to interrupt, but I think if you're wanting to advance slides, they're not advancing.
Okay.
You
So
probably
let's
go to
see.
slideshow.
Are you seeing the mushrooms?
No, we're not up to that. You're too ahead of us right now.
Okay.
So you were disclosing but not showing. So it's slideshow.
Let's see. What I'm doing now, I'm plugging my external monitors to see if that helps.
No, you're totally fine now. You're totally fine now. It just wasn't advancing in slideshow mode.
Okay, great.
But now you're
okay.
back. But you're back to that again, Matt. You want to be in slideshow mode.
Yep. So I am in slideshow mode according to my screen.
Just remove your next screen. Just stay with the laptop.
Yeah, I've removed the external screens. So let's see. Let's see if I can.
You're in presenter view. Swap presenter view and slideshow. I think that'll do it. That might do it.
Yeah, I'll give that a try. Yeah, I was according to my screen, so something's.
What have you been eating?
So let's see. Are you seeing it there?
Perfectly.
Okay. All right. Well, just give me a shout out if you're not. You should be seeing mushrooms. You're not hallucinating. You're really seeing mushrooms. Okay, here we go. So these compounds have an absolutely ancient and prehistorical history of use. I'm showing you some artifacts from Central and South America and in the middle and on the left. I'm dating back from several hundred to even 1,000 years. On the right, I'm showing you a depiction from a cave painting in Northern Africa dating back around 9,000 years ago. So that's several thousand years before the first human civilizations popped up in Mesopotamia. So very ancient history of use that is shown in some of that work. Fast forwarding to the 1940s through 70s, psychedelics, particularly spurred by the discovery, the synthesis of LSD, these were intensely investigated as therapeutic agents and just tools to research the mind and brain. Then we went through some decades of what I call the dark ages. There were certainly some casualties from the more reckless use, non-supervised use of psychedelics, and there was probably even a stronger factor was a very strong association with the counterculture and everything that was happening in the late 60s and early 70s, and because of this, research shut down for a few decades, and and during that time, at the beginning of that time, these compounds most of them were placed in Schedule 1 of the Controlled Substances Act in the U.S. And it's worth noting that it really wasn't the consensus that there wasn't strong scientific and medical evidence that these drugs couldn't be used with the proper safeguards in place. It was more of a reaction to the extra medical use and these larger associations. But now we're in the so-called psychedelic Renaissance or the Age of Enlightenment. I'm showing you the number of titles of scientific literature per year that contain the term psychedelic or hallucinogen, going back to the 80s, and you could see a steady baseline of a few papers a year up until the early 2000s, and this like rapid increase, and that just, it seems to be an exponential growth, and a lot of that has been human research and interest in therapeutics. There are certainly harms. These are powerful tools. I've published a lot on this, showing you some of those publications here. Don't have time to go into all of them, but like any powerful tool, there are certainly downsides, very dependent on the context. Kind of the biggies are the what people call the bad trip or challenging experiences. Sometimes without the right supervision, in a dangerous environment, people can hurt themselves. And so we have safeguards in place surrounding that. And then for a small percentage of the population that look to be dealing with active psychotic disorders like schizophrenia or show a strong predisposition for those disorders, there's a good signal that these drugs could exacerbate that type of mental illness. So for all of these harms, we have very good mitigation strategies at place through both screening, preparation, monitoring of sessions, and follow-up care. And if these compounds are eventually approved as medicine, I would certainly advocate and would strongly expect that those mitigating factors would be kind of baked into the regulatory approval. The sessions I'm going to tell you about are happening in a very particular type of session room, not your typical scientific laboratory. It's sort of as a comfortable living room looking environment. And so that's part of the safety, the safety factors at play, is having a comforting physical environment, but even more important, interpersonal environment. So here I'm showing you a mock participant with two guides, one of which is holding the hand of the participant, which is a powerful method for helping people through a difficult psychedelic session. So briefly, just our original research on psilocybin dealt with healthy normals. So that's scientific speak for people without a diagnosable problem. But of course, we're all humans and we all have our problems. But these were people that were interested in they were actively engaged in spiritual activities. The biggest take-homes from from the first study was that we saw improvements in mood and quality of life over a year after sessions from only a single high-dose psilocybin session. And we followed that up with a dose effect study. So the first study was just one single dose compared to an active comparator compound, sort of an active placebo. The follow-up study looked at 4 active doses of psilocybin as well as a true placebo. And the biggest take-home is that increasing the dose of psilocybin had a very orderly effect on the occurrence of mystical experience. I'll explain that in a bit. Challenging experience, which is what you can call the bad trip or an anxiety, panic type reaction, and long-term positive attribution. So clearly context plays a role in these sessions, but looking at these data, you can certainly see a very strong role of pharmacology. I mean, I'm showing you a pretty novel measure for a pharmacology study, the percentage of participants endorsing the session as being amongst the 5 most spiritually significant events of their life. And you can see just an orderly effect of that percentage increasing with the increasing dose of psilocybin. So I mentioned mystical experience. It might sound woo-woo, but it has a pretty solid basis in psychology. It measures a particular psychological experience. It's nominally distinct from any supernatural beliefs, although it could go along with those as well. It dates back to William James. This concept does, the father of American psychology, who found it remarkable that outside of drug use, that there were remarkable similarities across extraordinary human experience across the globes, from different languages, across the centuries, often from a religious perspective, but not always. So the kind of the core attributions of those experiences are having a sense of unity, such as all is one, being at one with the universe, a noetic quality to the experience, a sense of sacredness, transcending time and space, a positive mood, and ineffability, or it being beyond words. So in our research, we've both used existing scales and have psychometrically developed a scale, the first one called the MEQ30, the first one that's specifically designed to assess this type of experience on a particular day with something like the administration of a psychedelic compound, but it's available to be used for meditation interventions or any other type of acute manipulation in a research study. Combining those first two studies I told you about with healthy normals, we with that increased power from the combination of studies, we found an interesting observation. We found that psilocybin increased this personality dimension, which is called openness to experience. And what this openness to experience personality construct refers to is a broad-minded tolerance for the points of views of others. It's the ability to hold a both and rather than an either or framework. It also includes an appreciation for aesthetics, arts. So to our knowledge, this is the first relatively discrete experimental manipulation, for example, something you could schedule for next Tuesday, that actually changed a validated personality construct. The definition of personality is it doesn't change much. We know it tends to change a little bit with time and with certain life events, but not typically to, again, an acute intervention. And we found within that the mystical experience played an interesting role. The effect was strong enough so that statistically it was there for just everyone who, on average, who had received psilocybin. But if you break out your participants, as I'm showing you here, in terms of the ones who had a so-called complete mystical experience, they fulfilled criteria for all of those dimensions I told you about, versus people that fell short of that, you can see that it was the people having that full mystical experience that drove that increase before and after, that increase in personality openness due to psilocybin. So that's the first bit of data I'm going to show you that's consistent with that finding. Here I'm moving into the first therapeutic study using psilocybin to treat anxiety and depression in cancer patients. So it was 51 cancer patients. They all had life-threatening cancer. About a third had a psychiatric disorder associated with depression, about a third associated with anxiety, and about a third a combination of both. Not going to get into the weeds. Briefly, every one of these 51 people had 2 sessions. They had a high dose session, which was the real deal, and they had a trivial dose session or a low dose session, really meant to serve more of it as a placebo. And we just randomized the order in which they got that. And they were about a month apart. So yeah, they got high dose first, then the trivial dose, or vice versa. Here I'm showing you one of our major depression inventories, the Hamilton Depression Inventory on the left and the Hamilton Anxiety Inventory on the right. At baseline on both figures, I'm showing you people coming in both of those randomized groups. They're coming in at a very high level. This is a clinically severe range up in the 20s. Post one is about a month after their first session. So for the red people, they've had the red group, they've had the real deal, the high dose session. For the blue group, they've only had that trivial dose. So you see a dramatic reduction in the high dose group into the range of the scale where you wouldn't, it's not indicative of them having any clinical issues. So this is the normal range. Somewhat of a decrease with the low dose group, but not nearly as large. Probably that reduction due to both what we call the placebo effect and also the very strong rapport building that you do in preparation for these sessions, the 8 hours of contact time in this study. But then on post 2, that's 5 weeks after the second session. Now everyone has had the real deal session, whether it was 5 weeks ago or 10 weeks ago. And so now you can see both groups are now down to that very low level of symptoms. And remarkably, that's virtually unchanged 6 months later. And so this is, stemming from a single administration of a psychoactive substance, which is really unheard of in psychiatric treatment. And the same basic pattern follows for depression and anxiety. And we see that the reduction in depression and anxiety long-term is related to the assessment of mystical type experience on the day of their session. And this is even true above and beyond controlling for just the intensity of the psilocybin session or how strong that drug effect was. So it's not about getting hit over the head with a hammer with a strong drug effect. There seems to be something about these particular psychological experiences, such as having this sense of unity, that is predictive of long-term benefit, just like the openness finding. And then very recently in JAMA Psychiatry, our group published the first randomized clinical trial using psilocybin to treat straight up depression, so major depressive disorder, not in cancer patients. 27 patients. They were randomized to either to get it was a waitlist control design, so randomized to get the active open label treatment either sooner or after several weeks of delay. And we found that a very large reduction, very similar to the previous data I showed you in cancer patients, very large reduction in the people that were randomized to get it immediately and not to the waitlist group. And then once the waitlist group, once they had their session, what I'm not showing you here, the reductions in symptoms we saw for them was very much the same size as the immediate group. I'll show you quickly our psilocybin smoking cessation research. There's that earlier research using LSD to treat alcoholism in several studies. There was also some research treating heroin addiction. I thought if there's this signal of cross addiction efficacy, and there's plenty of anecdotes of that with other drugs, that that these sessions aren't necessarily just helpful for treating a particular form of addiction, but kind of broadly across addiction. So I thought, let's try cigarette smoking. It's a great model system of addiction, easy to quantify. But beyond all that, it's kind of a problem in and of itself. I'm showing you here on the screen the number of people that die across these different drugs, and it just absolutely, it's like 4 times more than alcohol, and it swamps the illicit drugs, so you can barely see them on this when you show them visually on the same figure. So kind of an issue above beyond itself. And the thing that really gets me, and what makes me so interested in smoking, is that most people in the United States, they want help. About 2/3, they want to quit. It's just they're unable to kind of realize that ultimately for themselves. We're always thankful for some press coverage in science in general, but you don't always control the headlines or the photos. So hopefully you've gotten, with my discussion of the risk, you've gotten the hint of that I'm not encouraging use by anybody. But I especially want to emphasize, definitely don't take this many mushrooms. That's a lot of mushrooms in that cereal bowl right there. Before I show you the results, for the smoking cessation study, I'll just tell you that these were real deal smokers. They'd been smoking over 30 years on average and smoked about a pack a day. It was a 15-week protocol with weekly meetings. So most of them had so-called cognitive behavioral therapy content. So this is standard content for quitting smoking, kind of preparing for it, keeping a smoking diary, keeping track of how much you smoke, and going over the reasons why you smoke. We had 3 psilocybin sessions ranging from a moderate to high dose, the first session being scheduled on their target quit date, which was assigned several weeks ahead of time. I'm showing you data from carbon monoxide, which is one of our biological metrics of whether they've been recently smoking. So it's like a alcohol breathalyzer, but for smoking. This was before psilocybin, this was after. You don't need to be a stats whiz to see you have a pre-post difference. And what that meant in terms of the average of whether they were abstinent at different time points, that was an 80% abstinent rate biologically confirmed at 6 months. And that held up at a very long-term follow-up of 2.5 years at 60%. And those are very large results. I mean, the best smoking cessation medications come in at about 20 to 30% success at 6 months. And we found, just like in that other research, that long-term success in quitting smoking was related to the mystical content of the session. So you'll see this theme that keeps repeating. We did some qualitative work. I won't go into it, but people had all kinds of, in these lengthy interviews, very interesting things to say about how the session, how it helped them quit. One of the biggest things, I think, was the insights into self-identity and their own particular reasons for smoking. So we're now in the middle of a randomized comparative efficacy trial, randomizing people to 1 psilocybin session. So it was 3 sessions in the last day, just 1 this time, versus versus nicotine patch, both with cognitive behavioral therapy. It's ongoing, and so if folks are in the Baltimore area, send interested folks on our way. We're recruiting with COVID, some COVID, protections at place. We're starting again, but right now, for the 44 people that have gotten to their 12-month follow-up, so there's going to be 40 in each group, ultimately 80 people, but we're most of the way done. So 44 people have gotten to the 1-year follow-up. And right now the results show 59% in the psilocybin group are biologically confirmed abstinent a year out, versus 27% with nicotine patch, which is just, it's results could change. But if they hold up to something like this, it would be better than anything that's ever been published in the smoking cessation literature. And won't go into details, but we published several studies on just assessing. I presented these data for years now, particularly with smoking cessation, which we've been doing for about a decade. And people, seem to always come up and say, hey, sometimes kind of quietly, like, this happened to me. And some days they'll say it happened a couple of years ago. Some days they'll say it happened 30 years ago. Back in the day, they quit smoking or they quit. So we launched a bunch of surveys cataloging this. And so with plenty of reports, thousands of people across these reports of people saying after a psychedelic experience, usually just to recreational use or just to explore, but without the intention for it to be therapeutically helpful, these reports of quitting smoking, quitting opioids, quitting alcohol, quitting cocaine, methamphetamine, cannabis, really across the board. We have reports of people saying that they just were inspired to quit or reduce their substance use because of a psychedelic experience. So the big, wrapping up here, the big question is, what the heck is going on? You should be suspicious of snake oil. Are you telling me this stuff works for everything? Well, we got to stick to the data, and some of the results are early but very promising. So we need to keep following the data. But if they hold up across these different disorders, like, I think the challenge is to understand the common mechanisms, because it doesn't seem likely that these are all just kind of independent dimensions. It's unusual enough for a particular medication to work for different forms of addiction, so to help people quit smoking, to help people quit an opioid addiction, et cetera. It's even stranger for that same drug to then be useful for, treating depression in cancer patients, outside of cancer patients, anxiety. What I think is going on here transdiagnostically is all of these disorders point to a narrowed behavioral and mental repertoire. Just very loosely speaking, people are stuck in these narrow patterns. And I think about that as addiction broadly defined, whether it's the repeated use of a substance, which has its own sort of thought loops associated with it, its mental ruts, or disorders that are more associated primarily with the mental ruts, but have behavioral manifestations like depression, thinking about yourself in a certain way, that people don't like you, that you're not going to make it, these self-persecutory thoughts that everyone has, but that are to some degree, but are overexpressed in depression, and people get stuck there. So I think that's the best way to think about this going forward. And we're trying to figure that out biologically. Don't really have time to get into that, but we still really have more to figure out. I think it really tells us beyond these drugs themselves, like it's going to tell us a whole lot about the nature of the human mind and brain. What's the role, which is a big mystery around, what's the role of these serotonin 2A receptors in the human brain? I think there's, given these effects, I think there's good reason to think they have a role in modulating meaning and behavioral and mental plasticity, a very important role in human civilization. And kind of summarizing that transdiagnostic description I just gave you, Michael Pollan quoted me describing that with this very unscientific sounding term called the dope slap effect. The key, apparently, I said at one point over dinner, is there power to occasion a sufficiently dramatic experience to dope slap people out of their story. Psychedelics open a window of mental flexibility in which people can let go of the mental models we use to organize reality. And I'd argue that's at play with the different addictions and with depression. I ultimately think of psychedelics. I wrote about this in a recent editorial a couple of years ago. Psychedelics as psychotherapy. They really amplify all of the most important processes that we know make for good psychotherapy. And I think in that sense, one of the beautiful things about them therapeutically is they're a beautiful bridge. I think they're bringing back psychology to psychiatry, which is at the roots of psychiatry, but, going back to the psychoanalytic days, a half century or more ago, but now it's become more of symptom reduction. It's just what pill to prescribe. This is a beautiful sort of, obviously a medication, but working through psychotherapeutic process, which is why I think we're getting this paradigm shifting effect where you can have one medication effect that has behavioral results a year later sometimes. So that's it. Just a huge number of people to thank. Can't name them all, but Roland Griffiths, Mary Cosimano, Al Garcia, Fred Barrett are some of the major players. And check out our website at hopkinspsychedelic.org. But yeah, so hopefully we have some time for some interesting discussion.
Thanks so much, Matt. We have some time and some fantastic questions, and I'll try to sort of group things together in a way. So, a question: to the extent that mystical experience seems to be very important, what would you say about the mostly anecdotal reports so far around microdosing being quite helpful with mood and anxieties? How does that all potentially tie together? And to the extent you see effects in animal models, how does that connect with, presumably different sort of mystical experience in an animal?
Yeah, the most important thing to note is we know next to nothing about microdosing, particularly in humans. My best guess is that what we're seeing is a whole lot of placebo effect combined with some real effect. And so the big question is how much, and for what particular effects, how much of it is each? Like, surely there's going to be some placebo effect going on. My bets are that amongst the anecdotes that I've come across and that have been conveyed to me personally, I think the most interesting thing is the potential for antidepressant effects. I bet there's something real going on there. We don't know that yet, but it's not a stretch at all to think that chronically taking these drugs at a small dose is very similar to traditional antidepressants. I mean, going back not only to the SSRIs, but then even the tricyclics, monoamine oxidase inhibitors going back over a half century ago, all working through, augmenting these monoaminergic neurotransmission, including serotonin. So this is, this would be chronically exerting effects at a particular type of serotonin receptor. And so it wouldn't be surprising at all if a microdosing model was effective for depression. I don't think it's as exciting. I think at best it would be another SSRI type drug, which I'm all for having more tools in the toolbox, but I'm more interested in this model where there's more of the psychological healing that seems to have a self-fulfilling prophecy and has kind of, it's going to be more in the realm of a long-term cure than ongoing symptom reduction. I do think people should be cautious about the ongoing use of microdoses, though, because we know that these drugs have effects at the serotonin 2B receptor, which is associated with certain heart valve problems. It's what got fen pulled from the market. Not likely a problem at all for taking these things a few times at high doses in these limited treatment models. But when you're talking about taking it twice a week for years, that becomes more of a credible question. And the last thing I'll say is there is evidence of different forms of neuroplasticity in animal models. It's plausible that that's going on with microdosing. We don't know whether that's connected to these long-term psychedelic effects that I've shown you or not. So there's a whole lot to figure out there.
Great. Thank you. A broad question. What do you think the next 20 years of psychedelic science will look like?
I think we're going to get the first psychedelics approved. And by that, I'd go even broader than the classic psychedelics. Certainly MDMA and psilocybin, I think if the data hold up, are going to be approved as medications. And then I think we're going to see a broadening of different indications, different compounds, and different treatment models. How you use these things. And so by multiplying those three factors, you probably have millions of combinations of things, because there's hundreds of psychedelic compounds in the waiting to be tested, and ones that haven't even been synthesized yet. So it's going to be interesting. I think there's going to be something. I do predict it's going to transform psychiatry in a sense, but I also predict there's going to be aspects of a bubble inflation. I think there's going to be, we're going to get into sticky territory with the so-called spiritual and religion, and that can be many things, but the religious aspect of this, and going to need to be very mindful about how this is rolled out in clinical practice so that we can avoid abuses of power. And yeah.
Which is definitely, a potential concern. So both broadly, any more thoughts on the potential pitfalls as psychedelics become medicine? And the question we have is the worst case risk to an individual from taking this. One of the fears is that someone is scared they could be seriously mentally impaired, or an ongoing bad trip, or a lot of different ways of explaining a similar situation.
So I think one of the biggest pitfalls is just the adherence to the types of safety guidelines that we use in research. And my strong recommendation is that if the FDA approves these compounds, that they require that as part of the REMS, the risk evaluation mitigation strategies that they can impose upon the use of a medication. Saying, for example, you have to do this in the clinic with people with special training. You have to be prepared for the experience. You have to have oversight, all of that. And if it's not done right, there will be casualties. I mean, there's going to always be some rate of casualties in any form of practice of medicine. I think the risk-benefit ratio, when done correctly, is extremely favorable compared to much of what we see in medicine. But if it's not done right, I think there's a risk of people underestimating how challenging a bad trip can be. You don't have to go far back into the history of psychedelic research. Not one, but two people escaped from the so-called Good Friday experiment in '63. One had to be chased down the streets of Cambridge and injected with Thorazine because he was trying to find the president of Harvard to tell him about the second coming. I mean, one person in Rick Strassman's trial in the 1990s with DMT. Actually, this was with psilocybin. He never published it, but he reported to FDA, escaped from the lab, called his spouse. He described it as a woman in the book, but it was actually a man. I don't know why you had to change the gender because you're narrowing it down to 4 billion people rather than 8. But anyway, the person escaped from the lab. Fortunately, they were fine. But if something like this happens and someone's harmed, like they just freak out and they run across, traffic. And, I realize a lot of people with plenty of experience with psychedelics say, oh, that's a bunch of hooey. They've done psychedelics plenty of times, never had that. There's plenty of people that have used psychedelics hundreds of times and say, yeah, on their 300th time, they had like something bad happen where it nearly killed them. And, and I have a file folder full of these examples of admittedly rare, but like these are highly intoxicating drugs. Sometimes people do fall from heights. Sometimes people do, end up in situations that can cause harm. So if those types of situations represent a pitfall for not only obviously that person, but then the entire field. So we really need to kind of be protective and make sure there's high safety standards.
So along that lines, the next question would be, how are the administrators or therapists of the substances trained, and what has been the general reaction or response, to the training, and focus, if you would, on what the training is and what that might look like going forward as you're at scale.
Yeah, so we've always used a mentorship model. So I've guided over 100 sessions. I started by being a co-guide in sessions where we typically have a primary and a co-guide, meaning one person is kind of the point person, in charge, and the other is sort of assisting. And so with that sort of mentorship model, if one does a bunch of co-guiding, and then they potentially move up to the level of a primary guide. But it's really this mentorship model of, I think some people are kind of, they have those therapeutic skills regardless of their credentialing. part of this, I think, is going to be personality. I think it's what we call the common factors in clinical psychology and psychiatry, the ability to establish a strong rapport with somebody, to really have a caring relationship within appropriate clinical boundaries, but to have a caring relationship for someone and have this team type mentality with them, to not be thrown off base, to, the last thing you'd want to do is look at the other guy and exude this sort of feeling of, oh, we've never seen this before, I don't know what to do. It's like having a calming presence, always having that bond with the person. So there are a number of programs that have either started or are working to start training programs for this stuff. I certainly envision that's going to increase. My colleagues and I have been a part of helping some of those training programs and helping to disseminate the way we do things. But I certainly anticipate there will likely end up being any number of kind of professional opportunities to go through that type of training. But I think it's ultimately going to take really kind of, and ideally in a coda guiding position, like being at one point or another in this mentorship type of model.
Got it. A question has come up. Some organizations that are pursuing medical use are requiring therapists to have a personal experience with these medicines, and others are not. Do you have any thoughts on that in terms of effectiveness of as a therapist?
I have not. I'd actually be curious. I'm not aware of any organization that is requiring that.
Requiring is overstating.
Yeah. So MAPS has a scientific protocol cleared by the FDA, which is actually an experiment in and of itself.
Yep.
Which the MAPS folks, have been really clear. I think to their credit, that's completely optional, and so their feelings are the same as mine. And I wrote a letter of support clarifying that our safety guidelines for them, when they were trying to get that past the IRB, that recommended that experiences with altered states of consciousness could be helpful, and kind of clarifying that, okay, if it's done legally and safely, that could be helpful as a practitioner. But some people would never, they wouldn't pass our screening, for example. They might have a cardiovascular issue, and so for any number of reasons. I do think there's also a danger in it's a complex one, it would have to be legal, because then we're in an interesting situation here where some people might have experience in their past from a less than legal exposure, and that's obviously a sensitive area. But I think an important, when the questioning comes up, I think a more important underlying question is whether there's this very strong empathy for the person, and also realization that even if the person has the guide has had experience themselves or not, they haven't had the experience that person has having. They don't necessarily know, and there can be the flip side of a false sense of authority. Someone thinking, oh, they've done this plenty of times, and not realizing that they don't necessarily know what this 68-year-old grandmother is going through with cancer on that particular day, on that particular time.
Oregon recently passed an initiative that will allow over a 2-year period, that is set up to allow over a 2-year period, the establishment of statewide norms, rules for psilocybin administration. Any comment on that? What does that do to the medical psychological model? Is this a good thing, a bad thing in your opinion, or any other comments?
Well, I think the question comes up a lot, or the questions come up a lot. I think one of the biggest things to know is that it really is sort of independent from the FDA process. And so the development of psilocybin is very different than the history of medical cannabis, where folks at the state level and local levels went forward with ballot initiatives because there's basically no path forward at the FDA level for whole plant cannabis. What we're doing with psilocybin is really more analogous to the development of Marinol back in the 1980s, and really has no controversy associated with it. So there is a very clear FDA pathway for medical use. So it's not that state initiatives are going to facilitate that FDA pathway. And my other but my other thoughts are that I really hope that that the 2-year, figuring it out period is, I hope they figure it out well. I hope part of their stated intention in the initiative is to integrate with federal authorities and not get into a conflict situation. I don't know how that could and would play out, but as much resonance and not to have this sort of conflict with federal authorities, I think that's critical. And then the other factor is that I think it's critical that they have it play the safety factors. What they propose is both sort of like healthy normals, so people without problems being administered the mushrooms, but also patients for the treatment and sort of, so I hope for safety on both those angles. But then there is also particular issues once you're talking about the practice of medicine, so that, you would certainly want the appropriate medical personnel involved at the appropriate stages of care.
Thank you. Thank you. Any comments about ketamine-assisted psychotherapy, utilizing the effects of ketamine, which is not a classic psychedelic, but is related to creating an altered state, certainly, as an adjunct to psychotherapy, as opposed to as an intervention, usually via IV for depression and suicide.
Right. I think there's an incredible promise. In fact, years before the approval of Spravato, which is the FDA approved version, of course, there's a lot of off-label use of intravenous ketamine, as you mentioned, that's going on legally, but also then straight up FDA, approval of the nasal spray formulation Spravato S-ketamine, and years before that, though, Evgeny Krupitsky in Russia published several papers on using ketamine very much as a psychedelic therapy, treating both alcoholism and opioid addiction, and reported very high success rates. And he was using it straight up, and by psychedelic therapy, I mean, rather than the Spravato model of, you might feel different, ignore that, it'll be over. That's a side effect that, we'll try to minimize and, just kind of don't pay attention to that. It's like, you're going to have an altered, experience, and the goal is to learn something from that experience. And we're going to discuss that experience afterwards. That's psychedelic therapy. And again, very, very promising results. He had to stop that line of research because Russia changed the scheduling of ketamine and no longer allowed it. So I know it's something a number of folks are interested in. I mean, I think one of the just huge questions, low-hanging fruit, is like, what does ketamine look like, when you can explicitly compare these models? The antidepressant effects last on average across studies about a week. Just administering, the modest dose, with, telling them ignore the experience. And will you see something more like these long-standing effects if you treat it more of like psychotherapy, psychedelic therapy, with the idea that if there's actual learning from those experiences, and if there is this speculatively, but it's not too far out there, if there are forms of neuroplasticity that are being invoked, especially in combination with that experience, is what's being done now, is it failing to utilize this kind of opening of a critical window? Can you actually reestablish new normal patterns during that opening of plasticity that would then be responsible for longer term benefit, which is my best guess of what we're seeing going on with psilocybin.
Thank you. Most of the studies and works are being done with, paraphrasing this question here, with drugs synthesized in the labs versus naturally occurring medicines. Are there possibly some entourage effects that are lost in that translation? I mean, you may want to just lay out for people sort of, all right, here are the positives, here's where you want to synthesize, you can control dose, et cetera. But then on the other side of their entourage effects that are not yet known about, that may be being lost somehow or another.
Yeah, the nice thing is, you said, Dick, like that's, working with psilocybin, that's the way the FDA doesn't ban natural products, but there are far more hurdles. And just scientifically, having a single molecule and just having 20 milligrams or whatever it is that reduces a lot of variability in natural products. It's not impossible. There are natural products that have been FDA approved, so you can go through a standardization process. But you also scientifically know exactly what's happening, like what receptors that molecule hits, what are the post-receptor signaling pathways and everything else you can study in terms of the brain and body. But I'll say that it's certainly plausible that there's an entourage effect. We know there are other tryptamine, depending on the mushroom, different tryptamine-based molecules like psilocybin and psilocin, which are the major ones, and they're really the same because psilocybin turns to psilocin almost immediately in the body, so it's really psilocybin that's working in the brain. But there's these other compounds, baeocystin and norbaeocystin, that in most species there's probably not enough there to actually have an effect, but we really don't know. That's speculation. Other species, they're showing up in higher concentrations, and it's plausible. For something like cannabis, even though I think it's typically overblown in the commercial market without any constraints on it, we do know, at least at the basic level, there is something to an entourage effect in terms of the effects of THC being modulated by co-administration of cannabidiol. So it could be that there's something going on like that, but it's empirically, it's a complete unknown at this point.
Great, thank you. That's a great segue into what are interesting potential psychedelic compounds yet to be tested in human trials.
Oh, one of the biggies would be 5-methoxy-DMT. If you talk to folks that know their psychedelics, that's usually in the category of, let's say, well, now this is something different. So I'm thinking sort of like DMT, it can be vaporized, and so really drawing across pharmacology, when people are vaporizing or smoking something, you get very similar effects to when you administer it intravenously. But these are just different ways to, one way or another, get it into the person's bloodstream right away. So just this so-called bolus effect right off the bat, and both with whether we're talking about IV or smoked vaporized routes, DMT is in that other category of just being, people say, orders of magnitude more intense than things like psilocybin and LSD, mescaline. People say very interesting things about 5-methoxy DMT too. People, all anecdotal, but people will say, the rates of mystical experience are even higher. It's just sort of that, like, immediately going to that sense of unity, and having this overpowering, psychological effect. So that's one of them. But then we have a whole cookbook. I mean, we have, if folks aren't familiar with Sasha Shulgin's PCAL and TCAL, he has hundreds of compounds that are explored there, many of which appear to be psychedelic, which are just waiting to be studied in clinical research. And then add to that a whole lot of other compounds that Dave Nichols and similar folks have also developed. So, I don't think it's an endless lane of discovery, because there's only certain size molecules that can penetrate into the CNS, but nonetheless, there are still psychedelics waiting to be discovered, different configurations.
Great. How do we keep the progress made from the successful psilocybin assisted therapy and other sessions going forward? What do you see as sort of the biggest opportunities and challenges in this field? And that's a broad question. And as we're coming to the top of the hour, that would be a great one to sort of, what does the future look like? What's needed? What isn't there? What do we want to be concerned about or looking forward to?
I think one of probably the biggest thing is just on the funding angle. I mean, we really need funding for basic research, both in non-humans and humans. And so it's understandable the philanthropy, which has been absolutely wonderful. And, I know, we and our other colleagues in the field are very thankful for, oftentimes it's not, it's totally understandably interested in, like, exploring a new disorder, and that pushes the boundaries in important directions. But kind of the thing that, like, NIH would normally support that may not be kind of the, the most attractive thing, for a philanthropist, you know, like really trying to understand these transdiagnostic mechanisms that are going on here. We really need the government, and also I'd say additional philanthropic support for basic research. And by basic, it very much, you know, basic research that is telling us how the clinical effects, the therapeutic effects are working. But we need the government to start, you know, stepping up and playing a role in funding this research. And so far, the NIH hasn't funded any therapeutic research with the classic psychedelics. I hope and expect that's going to change in the coming years. And yeah, and I think the support for junior researchers in the field, you know, when I hear about a promising postdoc or assistant professor that, and this happens, that, you know, they leave because the funding's not there, and you're just like that, like people don't realize, like, okay, there goes a huge chunk of the future of psychedelic research right there, because they couldn't get through this like 3-5 year period at the beginning of a scientist's career where you're at institutions where you're either going to get funding and stay there, or you're going to have to find a job elsewhere, get a job in industry or something. So supporting junior researchers in this area is huge.
Great. Well, Matt, thank you. And just to put in perspective, when you were originally doing this work, it was, you know, there was no funding. It was viewed as career limiting or destroying, and everyone thought you were crazy. And thanks,
that's right.
thanks to your incredible efforts and those of your colleagues, we're now in a place where, yes, more funding is still needed. Yes, NIH should be funding this, but there's a significant amount of both philanthropic funding and commercial funding, and, you know, the dollars involved in the space now compared to past years.
Absolutely. Yeah, we're in a great trajectory. Yeah. The field is doing well. So
Matt, thank you so much for your time today, and for, you know, the incredible illumination. And I thank everyone for joining today's call. Before ending the call, a couple of things. If you are a YPO member or spouse and interested in staying informed and learning more on the topics today, please join the YPO Psychedelic Medicine for Mental Health group for discussion boards, resource sharing, and other events. So again, Matt, thank you so much. I do want to let people know that we have another upcoming call, and you saw his book on the screen. Michael Pollan is going to be speaking on February 3rd at noon Eastern. So you know, we'll be getting his perspective on everything that's going on. So Matt, thanks so much. Thank you, everyone. And as a final reminder, that this GCC recording will be available in approximately a day or so, and we'll be sending out a link, and feel free to share that. Matt, thank you.
Thank you, Dick. I really appreciate it. Thank you, everybody.
Thank you all.
Thank you, Dick. Thank you, Matthew.
You're welcome.
Thank you. Thank you.
Thank you for your amazing work, Matthew.
Thank you.
Thank you, Dick. That was wonderful.